Hello everyone. Today we will discuss one of the most confusing topics among the plastic surgery, vascular tumors and vascular malformations. Historically, the tumors had a postnatal onset, endothelial proliferation, enlargement, and amenable to drug therapy, while the malformations were the quotient errors in vascular morphogenesis and were unable to be treated by drugs. But the new genetic basis has identified that there is overlap between tumors and malformations, and malformations are also being able to be treated by drugs. So let's start. Among vascular tumors, the first topic will be infantile hemangioma. Infantile hemangioma is the most common tumor of infancy. Incidence increases in premature. It is more common in female and it present at 2 to 4 weeks postnatal and increases till size till 9 months, and size starts decreasing after 12 months, and there is no improvement after 3.5 years. So there are proliferative phase, involuting phase, and involuted phase. 80% of the times it is unifocal, superficial, and red, and 20% times it is subcutaneous. Skin can be blue or normal. Diagnosis is confirmed by Doppler, which show fast flow and shunting. There are several phenotypes. There can be 5 or more small, less than 5 mm diameter lesions, and in those cases 16% have hepatic infantile hemangioma, which can be diagnosed with ultrasound whole abdomen. There are also associations such as faces and lumbar. In faces there is posterior fossa brain malformation, hemangioma of the face, arterial cerebrovascular anomaly, coarctation of aorta and cardiac defect, ear endocrine abnormality, and sternal clefting. The lumbar association is made by lower body hemangioma, urogenital abnormality, myelopathy, bony defect, anorectal malformation, and renal anomaly. Coming to the management of infantile hemangioma. If the infantile hemangioma is non-proliferative, we can observe if there is ulcer, bleeding, obstruction of the vital structure, or deformity. And if the lesion is superficial, we go for topical timolol 0.5%, 1 drop BD. If it is subcutaneous, injection triamcinolone can be given. Maximum dose is 3 mg per kg. If there is large infantile hemangioma, that is more than 3 cm, oral propranolol 2 mg per kg per day is given. If oral propranolol is contraindicated, we go for prednisolone 3 mg per kg per day. After the treatment with this, if there is residual disease, we go for surgery at 3 to 4 years. If there is residual telangiectasia, we go for pulse dye laser. Coming to congenital hemangioma. Congenital, therefore it is present at birth. One important point is there is a peripheral halo which you can appreciate. It is more common in extremity. There is equal incidence in male and female. Diameter is about 5 cm. There are two subtypes: rapidly involuting congenital hemangioma or non-involuting congenital hemangioma. By 1 year, if there is no symptoms, no intervention is done. But if there is symptoms of congestive heart failure, systemic corticosteroids or embolization is done. And if it is non-involuting congenital hemangioma, there is rarely problematic. Even if there is atrophic skin or subcutaneous tissue, we go for STSG or acellular dermis. Now coming for caposiform hemangioendothelioma. It is present at birth or develop at infancy. Equal incidence in male and female. Size is generally more than 5 cm. It can be flat, reddish, or edematous. Patient presents with pain and fibrosis. More than 70% of patient has Kasabach-Merritt phenomenon. It includes decreased platelet count, petechiae, and bleeding. Patient also has slow postnatal growth. If size generally decreases till 2 years, therefore there is partial regression which can be inferred as improved platelet count. Other phenotypes are tufted angioma, where there is more erythema and flags. Diagnosis is clinical diagnosis, but extent is confirmed by MRI and confirmation is by histopathological biopsy. Management. Sirolimus is the first line treatment. It is helpful in Kasabic merit phenomenon, decrease pain and fibrosis. Second line treatment is vincristine. If there is fibrosis and after that contracture develops, surgery is the treatment option. Now, coming to the last of the tumors, it is pyogenic granuloma. It is a small and red lesion which can occasionally bleed. Size is about 6 mm. Management is full thickness skin excision. If there is very small punctate sized pyogenic granuloma, needle tip cautery is more than sufficient. Now coming to the vascular malformation. Vascular malformation can be capillary, lymphatic, venous or arteriovenous. Coming to the capillary malformation. Capillary malformation is the most common malformation. At birth, it is pink in color and can darken with age. It is associated with overgrowth of subcutaneous muscle and bone. There are various phenotypes such as fading strain subtype, which at 2 years resolves on its own. The other is Sturge-Weber syndrome. There is capillary malformation in trigeminal 1 and 2 domain. There is ocular abnormality and leptomeningeal vascular capillary malformation. Other subtypes are heterotopic neural nodule, where there is scalp capillary malformation, tuft of hair and encephalophyll. Capillary malformation over the cervical or LS spine is associated with spinal dysraphism, lipomeningocele and T3 cord. Cutis marmorata telangiectasia, it affects lower limb, purple reticular appearance. Now coming to the lymphatic malformation. Lymphatic malformation. It can be microcytic if it is less than 2 mm size or macrocytic more than 2 mm size. Most common site is head and neck, axilla, chest and perineum. Overlying skin can be normal, blue, pink, reddish erythematous or vesicular. There are several phenotypes here also. The first is generalized lymphatic anomaly and Gortham Stout disease, where there is lymphatic malformation in bone, spleen, pleural, pericardial disease, and there is lymphectasia of the bowel, which is associated with protein losing enteropathy. There is PROS PIK3CA related overgrowth spectrum associated with lymphatic malformation. Klippel-Trenaunay syndrome. There is capillary lymphatic venous malformation and extremity overgrowth. Clove syndrome. Clove syndrome has congenital lipomatosis overgrowth, vascular malformation, epidermal nevus and scoliosis. Facial infiltrating lipomatosis, overgrowth of one side of face with mucosal neuroma. Here we can all see that all the phenotypes have common overgrowth thing. Coming to the management, if it is benign, no management is done. If it is macrocytic, sclerotherapy can be given. After that, surgery is done. If it is microcytic, there are several options such as surgery, injection, bleomycin, radiofrequency ablation and CO2 laser, or we can go for sirolimus and alpelisib. Coming to venous malformation. Venous malformation is blue in color. If large, MRI is done to check the extent. Venous malformation presents with pain, bleeding, ulcer, swelling, obstruction, deformity. It can also cause DVT and present as pulmonary embolism, and DIC can also develop. There are also several phenotypes. It is glomerulovenous malformation, cutaneous mucosal venous malformation. All are autosomal dominant and multifocal. Cerebral cavernous malformation, blue rubber bleb nevus syndrome. There is venous malformation in skin and GIT. Bockenheimer disease, venous malformation in entire extremity. Verrucous venous malformation, hyperkeratotic extremity. Fibroadipose vascular anomaly. And there it is intramuscular venous malformation. Management. Most common complaint is pain. Pain is due to phlebothrombosis. For this, aspirin is given. Low molecular weight heparin is also given in case of extensive venous malformation, because there can be localized intravascular coagulopathy which may lead to disseminated intravascular coagulopathy. Venous malformation can be treated with sclerotherapy every 6 weeks, and when it resolves, at last surgery can be done. Subtotal excision is better than complete excision, because other than cosmetic, most of the time there is no other cause. Or we can go for sirolimus and alpelisib. Coming to the last, arteriovenous malformation. In arteriovenous malformation, there is no capillary bed. There is direct artery to vein. Blood is passing. Patient presents with deformity, pain, bleeding, and congestive heart failure. There are stages of arteriovenous malformation. In the first stage, it is quiescent. Second stage, venous malformation, enlarge in size. At third stage, there is bleeding and ulcer. At fourth stage, congestive heart failure develops. On examination, it is pink or red in color. In Doppler, there is fast low. MRI can be done to check the extent. There are also several phenotypes. First is capillary malformation associated with AVM. It is also autosomal dominant, and here the capillary malformation is atypical capillary malformation where there is small multifocal and round lesions. Park-Weber syndrome is associated with extremity arteriovenous malformation. It is also autosomal dominant. There is also P10 hematoma tumor syndrome, which is also autosomal dominant. Management. First line management is embolism. Or we can also go for sclerotherapy of draining vein. And within 1 week, we have to go for surgery. Otherwise, there is re-expansion of the malformation. Off-label, trametinib MAP2KI inhibitor has also been tried at several centers. Thank you for watching this video.